Now the first thing, right lower quadrant, you think of is appendix, and that's often the first thing we look at. Now ultrasound is a great test. Ultrasound is very operator dependent, but it is a great test. And one of the best things about the test is it doesn't require a $1 million machine and it doesn't use radiation. So a lot better for younger patients, a lot better in countries that don't have access to so much CT. What are we looking for? We're looking for the appendix. And it's normally a finger-like structure, it's blind ending. We're looking for the size of it and whether it's sore, if you can compress it with the probe. It should be non-peristaltic, and that's a way to differentiate it from adjacent small bowel. And we classically look for a target sign like this, and we use a 6mm cutoff as a nice diameter, but I've seen a 10 or even a 12mm appendix on a CT that was completely normal. Hypervascularity, another sign. The trick though is the appendix moves around and is variable in location between you and I, but also between me now versus me in 20 minutes time. It will move around. And its various positions are illustrated here. And I like this diagram, one, because I created it, and, and two, because I can do this, and Dixon for some reason thinks that's hilarious. That retrocecal appendix, see how it's a bit shaded? It's behind the cecum. 2/3 of patients, 2/3 at any time, you'll find it there. That's really sucky for the sonographer, right? The sonographer's got a probe. Ultrasound's a great medical imaging modality, but don't like going through air that well. And guess what? The cecum's full of air and poo. So seeing a retrocecal appendix is hard. And that's why I think ultrasound has a bit of a bad rap with appendicitis, because it is hard to find. A great study, and we reference this as the 9th reference in our acute appendicitis article on Radiopedia, is this paper, and I love quoting it. And what they did is they said they were looking for appendixes on ultrasound, and they found it about 1/3 of the time, just with the patient lying supine. Then they would rotate the patient 45 degrees, left side down, and then they could find another 14%. And then they rotated them back, scanning all the while, and it takes 30 seconds, 60 seconds, right? And then they could get that up to 53. So they've gone from like 1/3 almost to 2/3 by just rolling the patient. And that's great. That might mean you're saving that 25-year-old female from having a CT. So it's a really good, important lesson that dynamic ultrasound and moving the patient is a really important part of what the sonographer will do.